Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Heather Landau, who is director of the Amyloid program at one of the leading cancer centers in the United States, Memorial Sloan Kettering Cancer Center. And she's going to talk to us about a trial that she presented at the recently concluded American Society of Clinical Oncology meeting, a novel approach to treating amyloid with CAR-T cells. Welcome, Heather.
Thank you so much for having me today.
So, to get started, what is this trial that you presented? We'll get into the details, but just to lay the groundwork.
Yeah, so this is the initial safety and efficacy data from our trial called NextCart-2. It's the first US trial of NXC-201, a novel CAR T cell directed against BCMA in relapsed or refractory light chain amyloidosis.
So, for those who may not be as familiar, could you put in context as to what the scope of the problem is?
Yeah, so based on US claims data, we estimate that about 23,000 patients with are living with or will develop relapsed or refractory AL amyloidosis. And this is a disease where there's not a single FDA approved drug available. This condition is akin to multiple myeloma. It starts with plasma cells in the bone marrow that make toxic light chains. But unlike multiple myeloma, these light chains aggregate and deposit in critical organs such as the heart, the kidneys, and the liver, and cause significant damage to those organs, resulting in morbidity and often mortality.
So, how is the disease treated today before we talk about this novel approach?
Yeah, so actually the anti-CD38 antibody, daratumumab, is the first and only approved drug for this condition, and it's been transformational, I'd say. So in the Andromeda study, which utilized daratumumab in combination with bortezomib, Cytoxan, and dexamethasone, compared to the same combination without daratumumab, the complete hematologic response rate was up to 60%, which again was very inspiring. However, that means that 40% of patients don't get a complete hematologic response or don't get an ideal response. And some of those 60% of patients may relapse in the future. And unfortunately, there is not a single other FDA approved drug for this condition.
So we're certainly in need of better therapies, and I think that the data that you presented and we will review was really astounding. So could you just tell us a little bit about what the drug is, this CAR T cell?
Yeah, so NXC-201 is a novel BCMA directed CAR T cell that is optimized based on three main modifications to reduce the intracellular signaling and off-target effects, reduce cytokine release, and enhance plasma cell binding. It's also manufactured in 10 days.
Oh, so it's pretty quick, what we call vein to vein time.
That's right.
So in this trial, who was eligible to enroll?
Yeah, so this trial is designed for 40 patients, and the patients who were included received at least one line of therapy, including a CD38 monoclonal antibody and a proteasome inhibitor. And they required measurable disease based on standard definitions, but we also included patients with a DFLC greater than 20 milligrams per liter with an abnormal kappa light chain ratio based on a few lines of thinking. And number one being that we know these patients who have a small but toxic light chain, if they get into a deeper response, they have improved outcomes. And if patients in the relapse setting progress beyond a certain threshold, then they're at significant risk of organ deterioration. Patients who were excluded were those who had prior BCMA therapy
Okay.
previously.
So, how many patients have you enrolled?
So far, well, up to the data cutoff for this presentation, we had included the first 10 patients in the safety cohort. So 3 had gotten the lowest dose at 150 times 10 to the 6th, and 7 additional patients had 450 times 10 to the 6th. And because there were no DLTs, we went ahead to the dose expansion phase with 450 times 10 to the 6th. And at the data cutoff of April 11, 2025, and as reviewed by the independent review committee, we reported on the first 10 patients in the safety cohort for this presentation.
So, could you give us a flavor for what these patients were like at baseline?
Yeah, so the median age was 67, but we enrolled patients up to 82 years old. They had median of 4 lines of prior therapy. 70% had cardiac involvement, and while they had advanced cardiac involvement at diagnosis, because these patients were relapsed and we don't allow them to have organ deterioration, they had less advanced cardiac disease at enrollment. We were very liberal with the creatinine eligibility and enrolled at least 1 patient with very advanced kidney disease with significant proteinuria and 2 others with more modest proteinuria.
So, how was the treatment tolerated?
Well, I think it was tolerated very well. As expected, 80% of patients did experience CRS, but it was all very low grade and predictable. The onset was a median of 1 day, and the duration was a median of 1 day. Interestingly, there has been no neurotoxicity, no ICANS, or any neurotoxicity of any kind seen with this product. Patients did experience neutropenia, but only 1 patient had febrile neutropenia and no infection in that setting. We did have our 1 patient who had advanced kidney disease, develop deterioration of their kidney function shortly after the CAR-T cells was not unexpected. However, the patient was discharged from the hospital after the initial stay and was doing well on dialysis and back to work when she then came in with a catheter-related infection and subsequently died at 5 months post CAR-T cell from complications of that, unfortunately. There were 2 other patients who had grade 3 infections that were easily manageable, and no patient had any significant cardiac toxicity.
And I gather there were some remarkable results.
Yeah, so on the left, I show the waterfall plot of the percent decrease in the DFLC from baseline, and all patients responded at a median of 7 days. All patients had normalized their marker at that time point or at last follow-up. We did see that the immunofixation, like many other CAR-T cell trials, persists for longer, but the free light chains normalized quickly.
But
then this rapid, on the right side, I show the rapid reduction in the DFLC, and remarkably, these were associated with also with organ responses.
That is what I was going to say, that the organ response is occurring so quickly. That's remarkable.
Yep, 2 out of 2 patients with cardiac evaluable disease had improved biomarkers by month 1 and 3. And again, 2 out of 3 with renal evaluable disease had improvement. Again, we did have 1 patient with renal progression.
And then you put up an anecdote, something that your patient told you.
Yeah, so actually, there was 1 patient who came into the trial very sick, was rapidly progressing, had seen multiple lines of therapy, and she felt compelled to share this with me. On 2 weeks after her CAR-T cells, she said, "It's been a week since I left the hospital at day 10 after those magic cells, and she's been comfortably walking 2 to 3 miles. Also on incline. She's somebody who is very symptomatic. She said she never thought she'd be feeling this strong and vibrant 15 days after her CAR-T cells, or guessed that she'd be experiencing less of the horrible leg fatigue, shortness of breath, and chest tightness that was increasing and weighing her down for the months preceding the trial." So this is a testament to the actual benefit in not just the numbers, but really and I could say that I think many of the patients felt this way. It was very patients are really feeling better, not just having improvement in their numbers.
That's amazing. And anything further to say about the independent response committee's assessment of the performance of this drug?
Yeah, so I would say that amongst the patients who had um, MRD tested, um, uh, 8 out of 9 patients were MRD negative at day 25, and 70% of our first 10 patients met the CR mark for by the independent review committee. The other patients were in a VGPR or a low DFLC PR based on the immunofixation that persists. But those patients who had not met the CR criteria are expected to evolve, given that their bone marrow is MRD negative. Many of those patients.
So, what's the main takeaways from the study to date?
In patients, I would say in patients who have a true unmet medical need, this product was delivered safely and efficiently. I didn't say that everybody had a vein to vein time of 14 days. Low grade CRS and no neurotoxicity of any kind was seen. All patients had rapid and deep hematologic responses very quickly. 8 out of 9 patients were MRD negative, with a total of 70% heme CR rate at data cutoff, and organ responses in 4 out of 5 evaluable patients. There has not been any heme relapses or progressions to date, and we are actively accruing in many centers at this point. And it's been a pleasure to be part of this transformational type of trial.
Certainly transformational. Obviously, this is a disease where patients are fairly debilitated and treatment options are lacking. We've had some recent negative trials with some antibodies, I believe, that came as somewhat of a disappointment and a surprise. So obviously, getting treatments like this out for patients would be very important. So where do you see the drug moving? When do you think it could be available for patients? Do you have any timelines, or is it too early to tell?
I think that we're hoping to complete the trial and have be in conversations with the FDA by the end of the year, or even early next year, given this really unmet medical need in this space. And, you never can predict what the FDA does, but hopefully, because there is really no other available drug for this condition and it is clearly safe and effective, there'll be some consideration for that, in the next, several months.
Well, that's remarkable. I really looking forward to getting more updates on these, astounding results, and want to thank you and your colleagues for all you're doing. And hopefully, these can be available for patients in the very near future. And I can have you come back and tell us more about this and other exciting developments in amyloidosis in the times to come.
Thank you so much for having me. It's been my pleasure.
Thank you.